Good morning, everyone, for this new episode on blood components and component preparation. I am Dr. Mohit Chaudhary and I am accompanied with my colleague Dr. K. Jaya Gauri. This is TransConnect and March 2023. This is a very important topic, especially for the PGs who have to learn this topic right for the theory and for the Viva, practical, everything. So this is like a long question which comes very often and very simple topic, but you need to know the basics and also know the intricacies of how the blood components are prepared and how each technician goes through the process, what are the quality control measures, and how we go about it. So the topic that we'll be covering is inclusive of two parts. We'll have this is the first part of blood component preparation where we'll be covering the introduction, the appliances of component preparation, the component preparation overview. We will be talking about three components and their modifications: the whole blood, red cell, that is the packed red cell, and the plasma. In the second part, which will be subsequently uploaded, we'll be talking about the component preparation overview again, along with the blood components like cryoprecipitates, platelets, and granulocytes. So coming to the introduction, blood component therapy is an integral part of the modern day healthcare. The shift whole blood towards blood component therapy has been a paradigm shift, and this is why whole blood is now considered as a raw product. What are the advantages of blood component preparation versus whole blood? Rational use of scarce reserves, so more than one patient can be benefited from just one single donation. Transfusion of the desired component, improved quality and functional capacity of the each blood component that is prepared, optimization of storage and blood components by appropriate choice of additive solutions. So basically you can increase the storage time, temperature, and the type of the bag, and reduce risk of transfusion reaction. So the ideal whole blood collection for components is total volume is plus minus 10%. So for a 450 ml bag that we use in our institute, it is 450 ml. So plus minus 10% is 405 to 495 ml. And similarly for 350 ml bag, it is 315 to 385 ml. When do we label a low volume red cell? Is when the up to 35% lower than the total volume. So 450, if we say is the total volume and we reduce it to 35%, it will be 300 to 404 ml for a 450 ml bag. Whereas for a 350 ml bag, it will be 233 to 314 ml. So what do you do with this? So whenever you label it as it's a US FDA concept. Whenever you label it as a low volume product, then you don't make any components out of it, just use it as a red cell. The under collected, when you say it is greater than 35% lower than the total volume, that is anything below the 300 ml for 450 ml bag and below 233 ml for 350 ml bag. Over collected is when it is greater than 10% of the total volume, which would be 385 ml for 350 ml bag and 495 ml for 450 ml bag. Transportation to the component room. So we all have a separate component room, whether it can be indoor or outdoor, but it has to be transported as soon as possible. In indoor, the platelet concentrate and FFP should be prepared within 6 hours of collection of whole blood. Sometimes we go in the camp. In those outdoor camps, the platelet have to be transported at 20 to 24 degrees Celsius. We all know that platelet agitation has to be done, but in these camps, you cannot do that. So it has been said that platelet agitation, even if we don't do for one day, it doesn't matter. It will not affect the functionality of the platelets. So you have special cooling plates which contain 1,2,1,4 butanediol wax which are available. You can use them. For FFP or cryoprecipitate, we transport at a temperature below 10 degrees Celsius. You have very good smart boxes available for transportation now. You can have gel packs or ice, but please remember that no direct contact between the red cells should be there, or because this can cause hemolysis. Now, portable temperature monitors are available. If you have them, it is very good to have and place them. This will record the temperature continuously during the transport. So how does it work? Component preparation, it works on differential centrifugation. We all know cells vary in size and density. They sediment at different centrifugation force. So anything which is dense is going to settle, like RBC. It's high density, it settles to the bottom. You can see the density of the RBC or the whole blood is or the specific gravity is 1.053. A low density will be medium would be in the top, like a plasma and an anticoagulant. So you can see the specific gravity of plasma is the lowest, it is 1.02, therefore it stays on the top. Platelet concentrate 1.03, packed red cell with additive solution is 1.06, packed red cell without additive solution is 1.08, and whole blood is 1.053 specific gravity. So how does it work? So we have a refrigerated centrifuge. This refrigerated centrifuge is used for preparation of blood components, should be regularly maintained and calibrated. It should be calibrated before initial use, after major repair or adjustment, and annually or every 6 months depending upon the hospital policy. The critical variables that affect the separation of cells from whole blood are the rotor size, that is fixed of course, the centrifugation speed, you can change that, duration of centrifugation, acceleration or deceleration. So this is a program that we have in our center where we prepare the packed red cell, FFP and Buffy coat. So the program is you can self assign a number to it. So it can be program 1 or 2, and you can then put the acceleration and deceleration along with speed, time and temperature, so that you don't need to change it every time. You just press the program number and that's it. What is RCF, or relative centrifugal force? It is nothing but ratio of the centrifugal acceleration and gravitational acceleration. So these two forces are going to act. So that ratio will give you a relative centrifugal force. So it is capital G upon small g. So substituting the formula, we get RCF as 1.118 into 10 raised to power minus 5 into R into n square, where R is the radius of the centrifuge. This is the rotor you can see, and the radius here would be the R, radius of the rotor of the centrifuge, and N is the revolutions per minute. So what are the appliances that we generally use in blood component preparation? We have a lot of plasma expressors. These are mechanical devices that make components flow from one bag to another. They can be both manual, you can see a manual here, and an automated here. So these pressure plates favor outflow of one component through top or bottom. And automated are of course better. They have consistent quality, they have higher yield, manual intervention is less, and better ergonomics. So this is another instrument that is very important, or an equipment which is very important, is scales. You have this weighing scales which weigh the volume of the bag. You need to note the volume of all the bags that you prepare. It is a mandatory requirement as per the Drugs and Cosmetic Act. It has to be validated periodically to ensure accuracy. Then you have this tube sealer, very important. These are radio frequency enabled devices which melts the tube, thin band that can be pulled, twisted off the rest, and there is series of sealing start from the close end. So when you start from the close end, it means that there is no pressure generated, and that is the better way of doing it. You don't start from the open end. So this is tube sealers are very important appliances that we have. Then you have another very important device which is sterile connecting device. This basically links two bags through a closed system without the breach of integrity. It is single use copper wafer heated and sliced through the tubing, and tubes are aligned and the wafer is removed. This causes melting of the tube, pressing and cooling ensures the connectivity. But before you start dispersing, you need to know that there is no leakage. So you always check for a leak. Then we have the refrigerators and deep freezer in which we store the blood components. They are important role in quality maintenance. You have to record the temperature 4-hourly. You have to check their performance. Only blood and components should be kept in those fridge. You can't keep the reagents and other material in the, or sometimes it's a blasphemy if you keep food or any eatables in it. So you keep only blood and blood components in the blood bank, refrigerator and deep freezers. It is 4 degrees Celsius plus minus 2 degree for the refrigerator and minus 30 degrees Celsius for the deep freezer. You should have an alarm if possible. You can have a automated system or an automated alarm where you may be informed even when you have when you are at home. So that is also possible. And you should always have an alternate power supply. Now these we are all familiar with. These are platelet agitators. The platelets have to be stored at 22 degrees plus minus 2 degree, and with constant agitation. The constant agitation basically helps you to for a better gaseous exchange and decreases the formation of lactic acid. So the viability of the platelet remains better. And Of course, the temperature recording has to be done every 4 hourly. Performance checking has to be done for these, the calibration every 6 months. So horizontal agitator is the one that we use. It has 60 to 70 oscillations per minute with continuous and gentle, which is continuous and gentle. An alarm is must for all these equipment because there can be a power cut, and this is very important because you are storing a very important product. You know that you are even storing these platelets at a room temperature. So the only precaution that you should take is that it should be sterile when you're doing the process. Your equipment should be clean because platelet out compared to all other blood component, platelets are the one which are implicated in any septic reaction. So you have the agitation. What does it does? It maintains the platelet metabolism. It causes an effective gas change and effective lactic acid exchange. So lactic acid is not produced, the pH is not reduced. You know that pH of the platelet should be more than 6.2. So now coming to the component preparation itself. Now I would call upon my colleague Dr. K. Jaya Gauri, who is going to take you through this process of component preparation specifically for whole blood, packed red cells and plasma. Over to Dr. Jaya.
Hello everyone. So we'll be seeing an overview of the component preparation. So once we obtain whole blood from phlebotomy, we can directly use it for whole blood purposes by doing it through a filter. The next option is doing a hard spin or a soft spin. If we need PRP, that is platelet rich plasma, which has its own indications, we go for a soft spin. Soft spin is nothing but a speed of 1080 RPM for 7 minutes. So when we do this soft spin, what we get is an RBC layer and a PRP layer. So the RBC with or without additive solution and with or without filtration, it is sent for storage. The PRP can be used for multiple indications. If we are going to obtain platelet and plasma separately from a PRP, we have to put the PRP through a hard spin. Hard spin is nothing but 3860 RPM for 9 minutes. So when we do a hard spin, what we get is a layer of platelet and plasma. The plasma is then subjected to freezing. The platelet is also sent for storage. Now, if we are not planning for taking a PRP, the other method is that we can directly put the whole blood to a hard spin. The hard spin will first initially separate the plasma, and then there will be an RBC and then a buffy coat layer. The buffy coat layer that is in between will then be subjected to a soft spin. After soft spin, we obtain random donor platelets. Now, if we need cryo, all that we have to do is take the frozen plasma, thaw it and subject it to a hard spin. If we subject it to a hard spin, there will be a cryo poor plasma and cryo. The cryo will then be subjected to storage with or without cooling. If we go on to the type of components, there are cellular blood components and acellular blood components. The cellular blood components include red blood cells, platelets and granulocytes, and the acellular blood components include fresh frozen plasma. Plasma of all varieties. We'll see each in detail. First, whole blood. Whole blood is the main source material of all blood component preparation. Whole blood is now become obsolete and is rarely used for transfusion. One of the few indications of whole blood transfusion is severe traumatic hemorrhage when platelets are not available in case of a military setting, etc., and in exchange transfusions. Whole blood units that are collected in blood bags containing CPD has a shelf life of 21 days, while CPDA1 has a shelf life of 35 days. Whole blood stored at 2 to 6 degrees centigrade has the following disadvantages. The labile coagulation factors will deteriorate rapidly and the platelets get activated, losing its function and viability. There is another entity called reconstituted whole blood. It is nothing but pooling of two different components, that is RBC and plasma, providing a reconstitution whole blood kind of a scenario. This is usually done in neonatal exchange transfusions. What we do is we take group O RBC, that is an antigen negative RBC, and a group AB plasma, that is an antibody negative neutral plasma. Both of this is reconstituted and given for transfusion. This product can undergo radiation, irradiation and washing, depends on the situation. Coming to the quality control of whole blood, based on appearance, there should not be any hemolysis, turbidity, visible clots or frothy appearance. The volume should have a range of plus or minus 10%. the anticoagulants must be appropriate and proportional. That is 49 ml for a 350 ml bag and 63 ml for 450 ml bag. Regarding hematocrit, the hematocrit should be in the range of 30 to 40%. Packed red cells. Packed red cells are obtained by separating plasma from the centrifuged whole blood. If it is CPD, the shelf life is 21 days. If it is CPDA1, it is 35 days. The total hemoglobin content of a PRC depends on two main factors. One is the pre-donation hemoglobin of the donor, and the second thing is the processing. Coming to the quality control of a PRC without additive solution. Regarding appearance, it's the same. There should not be any hemolysis, turbidity, clots or frothing. Regarding volume, it must be plus or minus 10% from 150 to 250 ml. The hematocrit should be 65% to 70%. The next thing is buffy coat reduced additive solution added red blood cells. That is, following centrifugation of the whole blood, the plasma is removed and there is a buffy coat formed. The buffy coat is also removed, which will finally end up in giving us the packed red cells. Now this red cells is then added to an additive solution. The additive solution contains substances like sodium chloride, adenine, glucose, mannitol, carbonate, citrate, phosphate or even guanosine. All these compounds in various combination and various amounts. There is a number of additive solutions available, which is a topic for itself. Now the volume of additive solution that we add depends on the whole blood collected. That is 450 ml we add 100 ml of additive solution, 350 ml of whole blood we add 80 ml of additive solution. Now removal of buffy coat is very important for two main reasons. One is that it reduces the leukocyte count of the RBC, thereby reducing febrile transfusion reactions. It removes the high energy requirement cell population. That is, once the high energy requirement cell population are removed, the quality of storage of RBCs improves and the metabolism of RBC is also improved. Therefore, addition of additive solution increases the shelf life of a PRC to up to 42 days. Coming to the main quality control of red cell concentrate with additive solution, the appearances, there should be no hemolysis, turbidity, clots or frothing. Volume same plus or minus 10%, but here the hematocrit should be between 50 to 60%. Coming to leukoreduced RBC. Leukoreduced RBCs are nothing but from the PRC, the WBCs that are mixed with them are removed. These have three main advantages. One, it prevents febrile non-hemolytic transfusion reaction. Two, it prevents the HLA alloimmunization in a multiple transfused patients. The third thing is it prevents the transmission of leukotropic viruses, especially cytomegaloviruses. There are various methods to do leukoreduction, but the most commonly preferred method are the filters. So leukoreduction can be done at three main stages. One is before storing. Number two is just before issuing. Number three is bedside of the patient. Coming to the quality control of leukoreduced RBCs. In case of leukoreduced RBCs, the leukocyte count should be less than 5 into 10 power 8 per bag. Coming to pre-storage leukoreduction. Pre-storage leukoreduction is nothing but a leukoreduction done soon after the preparation or within 5 days of collection of whole blood. Two main advantages. One, it removes the leukocytes before it disintegrates and releases cytokines. These cytokines are nothing but biological response modifiers, that is BRM. There are two main examples of BRM. One is the pro-inflammatory cytokines such as interleukin 6, interleukin 1 and TNF alpha. The second thing is complement fragments, that is C5a and C3a. Now, since these leukocytes along with the cytokines that they are supposed to release are removed, it improves the in vivo red cell quality because it also removes the highly metabolically active cells. Good clinical practice protocol can be applied. A wonderful QC can also be performed. Just before issuing, if you do leukoreduction, the method is actually easier and it can be easily incorporated and standardized, but the cytokines that has already been released from the leukocytes cannot be removed. Bedside leukoreduction, bedside leukoreduction has more amount of cytokines compared to before issue or pre-storage. No good laboratory practices protocol can be applied and no QC is possible. Coming to saline washed RBCs. Saline washed RBCs are indicated in the following situations. When there is a history of severe allergic reaction to blood products, when an IgA deficient recipient has antibodies against IgA and IgA deficient RBCs are not available, Antibodies against ABO group can be removed while transfusing for a HDN patient. Substances can be removed, mainly potassium. If the potassium level of the blood bag is too high, then it might cause a cardiac arrest in the recipient, but this potassium level can be reduced by saline washing it. The red cells are washed with 1 to 2 liter of saline, that is 0.9% sodium chloride, by centrifuging it at 4 degrees centigrade. There are automated red cell washers also available. Washing has two main features. One, it removes the electrolytes, that is we saw about potassium previously, and then it removes the plasma proteins also, that is all the antibodies, etc. It actually also removes 85% of leukocytes from the PRCs, but this removal is not sufficient enough to prevent alloimmunization. If the red cell is washed in an open system, use within 24 hours. If it is washed in a closed system, we can use up to 14 days. Next important aspect is irradiation. Irradiation of red blood cells is done to prevent transfusion associated graft versus host disease. Basically, the irradiation inactivates the T lymphocytes of the donor. So the T lymphocytes of the donor cannot attack the cells of the recipient and cause graft versus host disease. So irradiation can be done by two methods. One method is the gamma rays from cesium-137 or cobalt-60. The second method is X-rays. So a unit of 25 gray should be available at the center of the bag, while at least a minimum dose of 15 gray should be sufficient in the periphery. Irradiation sensitive labels should be used. The irradiation indicator should be placed in the indicator. If it indicates 25 gray, it has to be placed at the center of the bag. Now this irradiation has one side effect. It causes efflux of potassium outside the red cells. So that will increase the potassium content of the blood bag. So therefore, if the blood bag undergoes irradiation, it has to be used within 28 days post irradiation or within its expiry date, whichever date is earlier. Next concept is the frozen or cryopreserved RBCs. The RBCs are stable for prolonged periods in a frozen state. This is usually done to preserve the blood units of rare phenotypes or to build a blood inventory for emergency use in case of disasters. Always we have to froze RBCs along with cryoprotective agents. This will avoid red cell dehydration and intracellular ice formation. The most common cryoprotective agent used is the glycerol. Glycerol has to be mixed with the RBCs in a slow, constant way. If it is done rapidly, it will cause excessive hemolysis, and when the unit is thawed again, there will be a poor red cell recovery. Frozen RBCs can be stored up to 10 years. Cryopreservation with glycerol has two different methods. One is the high concentration glycerol and second is the low concentration glycerol method. In case of high concentration glycerol method, 40% glycerol is used. The freezing is done in a slow rate, slow rate, but controlled freezing is not necessary. The initial freezing temperature begins with -80 degrees centigrade. A mechanical freezer is sufficient for high concentration glycerol method. Shipping can be done with dry ice. Special deglycerizing equipment is required and the deglycerolizing time is 20 to 40 minutes. In case of low concentration glycerol method, 20% glycerol is used. The freezing rate has to be rapid, but controlled freezing rate is also required. The initial freezing temperature is -196 degrees centigrade. The type of freezer here is liquid nitrogen, which is a tedious kind of procedure. So generally high concentration glycerol that requires a mechanical freezer is used. The deglycerizing time is 30 minutes and special equipment for that is not required. So how do we recover the frozen RBC? We initially thaw it at 37 degrees centigrade for 10 minutes. The glycerol must be gradually removed from the thawed RBC by washing. So how do we wash? We initially start with 0.9% sodium chloride and subsequently decrease the osmolarity and end with 0.2% dextrose solution. So usually if it is done in an open system, it has to be used within 24 hours, but there are automated closed systems also available. When the final product, the thawed RBC that is ready for transfusion, the product should be free of cryoprotective agent. It must have minimal amount of hemolysis and the yield should be at least 80% of the RBCs that was initially frozen. Coming to PRC aliquots, they are nothing but small packets of PRCs designated for small volume transfusion for pediatric patients. The advantages of such preparation is that there is limited donor exposure, decreased blood wastage, prevents circulatory overload in the recipient. It can be done in two methods. One is the multiple pack system method. That is, already there are multiple packs, multiple continuous packs, so the product can be directly transferred. The expiry date of the small packs is same as the larger RBC pack. Next method is the sterile connecting device. We take a transfer bag, connect the tubing with the sterile connecting device, and then we manually transfer it. The expiry date here also is the same since a closed system is maintained. Coming to plasma. Plasma can be obtained from two different methods. One is the differential centrifuge method and second is the apheresis method. The whole blood collection time should not be prolonged when you are preparing plasma. If it is prolonged, it will lead to consumption of coagulation factors. Once the whole blood unit is collected, suppose if it has to be transported from somewhere outside, it should be transported at a temperature of below 10 degrees centigrade. This is important to maintain the coagulation factor activity because labile factors usually deteriorate rapidly if it is stored at 2 to 6 degrees centigrade. Plasma mainly contains proteins such as coagulation factors, albumin and immunoglobulin. Plasma is also a source material for plasma derivatives, which itself is a topic. Fresh frozen plasma. Fresh frozen plasma has to be prepared within 6 hours after blood donation. Ideally, the time taken to freeze plasma to the core temperature, that is less than minus 30 degrees centigrade, should happen within 1 hour. 1 hour of initiation of freezing. So FFP mainly contains normal amounts of coagulation factors, antithrombin and ADAMTS13, deficiency of which causes TTP. The shelf life of a fresh frozen plasma is 1 year when it is stored at a temperature of less than minus 30 degrees. The PVC bags that is used for storage has to be handled very carefully because at such low temperatures the bag will be very brittle and it is subjected and it will cause breakage if it's not handled properly. So once the FFP is thawed, it can be stored for up to 24 hours at 1 to 6 degrees centigrade. We usually avoid preparing FFP from multiparous female donors. This is to prevent TRALI because transfusion associated acute lung injury has been associated with HLA antibodies and a multiparous female usually has more alloimmunizations. Quality control for FFP. Regarding appearance, it should not be ectremic, it should not appear lipemic, there should not be any other discoloration. Regarding volume, if it is from a 350 ml bag, it should range between 180 to 220 ml. If it is from a 450 ml bag, it should range between 220 to 300 ml. Regarding sterile coagulation factors, 200 units should be present of each factor. Regarding factor 8, 70 international units should be present per bag. Regarding fibrinogen, 200 to 400 milligram is supposed to be present in a quality bag. Coming to pathogen inactivated plasma, there are various pathogen inactivators that are available to eliminate pathogens from the plasma. Most main points include pathogen inactivators include methylene blue, sorrelin, that is amatocillin with ultraviolet A, riboflavin and solvent detergent method. The solvent detergent method and sorrelin has been approved by the US FDA. Coming to methylene blue, the methylene blue is initially added to the thawed FFP, following which it is activated using visible light. The nucleic acid strands of the pathogens break and there is lipid peroxidation of the pathogen's lipid bimembrane layer, leading to a surrounding membrane protein modification. The plasma is then again refrozen after removing the methylene blue using a filter. In this method, there is a 15 to 20% loss of factor 8 fibrinogen. Coming to amatocillin method, as we can see in this picture, the collected FFP is made to pass through a bag containing the chemical compound, after which the chemical compound along with FFP is added to the next bag. Now this bag is subjected to illumination by UVA. In methylene blue, it was visible light. Here it is UVA light. So once it is exposed to the UV light, the content in the bag is then subjected to a compound absorption device. Now this will remove the chemical compound and the final product is obtained for storage. In amatocillin method, the activity of coagulation factors or antithrombotic factors is not affected. The next method is the riboflavin followed by UV light illumination, that is a mirror system. Here there is no necessary for removing the riboflavin because it is a naturally occurring vitamin and it does not require removal. Here it is released after the plasma is subjected to inactivation. It can be directly issued or it can be frozen for further storage. Coagulation and anticoagulation proteins are also found to be well preserved in this method. The next important activator is the 1% tri-N-butyl phosphate and 1% triton X100. Now what it does is it destroys the lipid bimembrane layer. So any viruses that is bound by a lipid envelope will undergo lysis. In this method also coagulation factors is decreased by 10 to 20%. There are another few plasma types called PF24, PF24RT24, liquid plasma, etc. Here the word F stands for frozen. That is, now we have obtained FFP, but within 6 hours we did not freeze it. Then they become PF24 because they were frozen but within 24 hours after phlebotomy. So they have a shelf life of 24 hours if it is stored between 1 to 6 degrees centigrade after thawing. Now there is another entity called PF24RT24. That is, the plasma was held in the room temperature for up to 24 hours after phlebotomy and before freezing. So freezing did not happen within 24 hours. That is PF24. For 24 hours, the plasma was in room temperature, after which freezing was done. That is PF24RT24. This also has a shelf life of 24 hours if it is stored at 1 to 6 degrees centigrade after thawing. There is another entity called liquid plasma. That is a whole blood which is stored, is directly centrifuged, and the liquid plasma is obtained any point of time during the storage. Now this has a shelf life of even 5 days after the expiry of the whole blood if it is stored under 1 to 6 degrees centigrade. Another entity is thawed plasma. Now the frozen plasma is thawed. We already saw it, the FFP has to be utilized within 24 hours after thawing. Now if it goes beyond 24 hours, it can still be used for transfusion if it is stored at 1 to 6 degrees centigrade. There is decreased level of labile coagulation factors, but AD-AMTS 13 levels are maintained. But this thawed plasma technique, that is more than 24 hours technique, is not licensed by the Indian Drugs and Cosmetic Act. The another entity is the pooled plasma. That is, it is done for therapeutic plasma exchange. Now this procedure requires multiple liters of plasma even for a single procedure. So pooling of plasma can be done up to 3 liters at a time. Thank you so much.